All right, now I'm going to go back and share, and hopefully not share anybody's stuff. That's not what I'm supposed to do. All right, so where is my PowerPoint? 29. All right. You seen the PowerPoint?
Yes.
Okay. Why is this? No. Sorry about that. Okay. Let's try this again. All right. So let's talk about ventilation first. So let me ask this while you guys are, because you guys know about anatomy and physiology, what are some things that pediatrics has that's different than adults in terms of their anatomy? What did we review in terms of kids? Let me ask, how do they show up in terms of respiratory distress?
You see retractions like around their ribs
Okay,
on the
good.
bottom.
Yep, intercostal, rib retractions. What else?
Grunting and nasal flaring.
Mm-hmm. Very good. Grunting, nasal flaring, those are the key ones besides vital signs. Now, just so I can't manage you if you're texting and you're outside of the texting window, but I could see your faces in terms of trying to talk to each other. So let's focus on the lecture. Brittany, I need you to get your camera back up when you get a chance. All right. Let's see. So we're going to talk a lot about oxygenation and ventilation. And sometimes we do oxygenation, ventilation mismatch, meaning we're hypoventilating, but the oxygen level is high. So when I talk about ventilation, I'm talking about the process of breathing air into and out of the lungs. So, for example, you guys were sharing when there's respiratory distress, we're seeing more and more of those accessory muscles being used. And when we say accessory muscles, we mean these intercostal muscles. Intercostal meaning between the ribs. And that's why you get those retractions that are seen. Very detailed when it comes to infants or when someone's dehydrated. Okay. And then also the diaphragmatic action. So diaphragms usually innervate and ventilate parasympathetically, right? But as you are having more and more difficulty, that gets driven by your sympathetic. And so you intentionally breathe and use that diaphragmatic change in your chest cavity pressure. In terms of breathing, what's the stimulus that's used in order for our respiratory center to have us breathe faster? What stimulates, what chemoreceptors, what are they responding to in order to trigger our respiratory center to breathe faster? So I'm talking about chemoreceptors on this slide. What do I mean?
The chemoreceptors sending signals to the pons in the brainstem.
Yeah, but what kind of chemical are they responding to?
Carbon dioxide?
CO2.
Mm-hmm. Right. So your levels of CO2 are the drivers of your pons increasing your respiratory rate. Okay, so they're a big part of ventilation. Your brain in your pons responds, and your respiratory responds to elevated levels of CO2. Now, when I'm talking about that titrated pH, right, 7.35 to 7.45, if I have elevated CO2, what kind of pH am I looking at? Am I alkalotic? Am I acidotic? What am I?
Alkalotic,
Alkalotic?
right? Because acidotic is when it's lower, right?
If I have a buildup of CO2, how does that show up in my blood work? How does that change my pH?
Wouldn't it go lower? Would it
Which
be
means
acidotic?
that's
Would it be acidotic?
acidotic. So it's acidotic. And if you think about that, when we hold our breath, right, that carbon is buffered to be an acid. Okay, and that's what's going to trigger your respiratory center. All right, besides that, when we're very young, our nasal passage and our throat, so our pharyngeal airway, there's a lot of mixing between the nose and the mouth. In fact, as a baby, we just suction both areas. They're pretty much have a big thoroughfare between them. Why is that important for us to know? Especially with diseases that we're going to come up that have a lot of mucus. Why is that important? Am I pausing, you guys? You guys can hear me, right?
Yeah, what was the question?
Okay, so if I have a nasopharyngeal area that is very open, like when you're an infant, those two between your mouth and your nose are not as separate as we are in adults. So the anatomy isn't as grown. There's a lot of mixing of the mucus there. What can we be more at risk for as an infant?
Aspiration?
Aspiration, definitely. So that bulb suction is going to be real important when we look at infants and their respiratory tree. So I'm pointing out the key differences. As we grow, our anatomy grows, we start compartmentalizing our areas a lot more, and then we aren't at, we lessen that risk for aspiration. So the very young and the very old are the ones that are most at risk, okay? Questions on anatomy. Obviously, the respiratory tree, right? We start with our upper airways, right? So we have our pharynx, larynx, goes to our trachea. In order for our trachea not to get fluid, what is on top of it? What closes when we swallow?
Epiglottis.
The epiglottis, exactly. So then we have our bronchial, right? And then our bronchioles, and then out into our respiratory tree. What is at the end of our respiratory tree?
Alveoli.
Alveoli, okay? And what happens at the alveolar level? That's very important.
Gas
Oxygen.
exchange?
Gas exchange.
Right.
Absolutely. So when you're building your care plans around respiratory, it's either a ventilation issue where I can't breathe and use those accessory muscles, or a gas exchange issue at the alveolar level where I can't onboard and offboard O2 and CO2. Okay? So depending on the diagnosis you choose, it's what part of the respiratory tree is affected. Like, let me ask you about asthma. Is that an upper or lower respiratory issue?
Lower.
Where is the asthma and constriction happening?
The bronchioles.
Bronchioles, right? So bronchioles isn't considered lower per se. Okay, it's still kind of an upper respiratory. So we'll review the anatomy when we go through each of the diseases. All right, so we'll start at the top. Nasopharyngitis, inflammation of the upper respiratory infection. This is a fancy term for the generic cold, right? Who in here has had a cold? Everyone, right? Everyone has a cold. It's going to be harder and harder for us to get rid of because of our viruses that are keeping, they're transforming, right? So coryza, also known as a cold, is the most common infection of the respiratory tract. This we will keep you in your profession for years and years to come. Like this is your bread and butter of what you're going to treat, especially as a NP. It's just because of how we are in terms of interacting with each other, the nasal discharge and the coughing, especially when it comes to pediatrics, it's so easy to share this with each other, okay? So nasal discharge, irritability, sore throat, cough, general discomfort, that is nasopharyngitis, okay? If we don't treat it at the nasal and pharyngeal level, then it becomes bronchitis. If it goes into our alveoli and starts forming particulates down there, then we say that it's pneumonia. Or if it wanders outward into our canal, then we're going to call it an ear infection. Okay, so depending on where the virus attacks.
Can you repeat those parts one more time?
Sure. So I'm at the bottom of the slide right here. As we treat the colds, and again, what's the treatment for viruses? Because it's cold virus. What do we do with viruses?
Antivirals.
Write it out.
Antibiotics? No.
Hydration and
Rest.
rest. Yeah.
We gotta just write it out. And this is where we have to do a heavy instruction. So because this is a viral infection, a cold is a viral infection, if we don't treat it with isolation, rest, recovery, hydration, and we give antibiotics instead, sometimes we perpetuate it for longer and it becomes a bronchitis. Or if it affects the alveolar level, then it's the pneumonia. Or it can wander outward to our ears and become an ear infection. And why do more kids get ear infections than adults?
Because their tube is like straight instead of curved.
Absolutely. So anatomically, remember when we take temperatures, tympanic temperatures, what are we pulling? Up and back or down and back for kids?
Is it down and back?
Is it down and back? Sorry, I'm telling my family to be quiet. I'm on Zoom, Sophia. Okay, so on examination, what are we doing?
Down and back.
To take a tympanic, okay, I'm trying to get your, I'm trying to get a good picture here. We are going to pull in, so their canal is straight back. We are going to pull down and back to open up the canal. Adult, up and back, okay? Because their canal is straight, that means that a lot of fluid can't drain as we do in adults. And a lot more fluid can get in easier. So a lot more ear infections, a lot more infections in general because of the anatomy. Okay. So this is what nasopharyngitis can either be a cold or it could be allergies. And sometimes those get mixed up. What are the differences between an allergy and a cold in terms of how it presents? You've had both, right?
Allergies have sneezing, but you don't really sneeze with a cold.
Good. Okay, so sneezing, itchy eyes, okay, versus colds tend to be febrile, bacterial higher, viral, low-grade fevers, okay? And then colds generally are malaise, where they have a generalized, you feel like, oh God, I'm getting a cold. My whole body is like tingly and just, I know something's coming on. Versus allergies tend to just hang out in this upper area. So allergic rhinitis, whether it be to something that's in the air, like recently Tracy had a big fire, that smoke gave a lot of people allergic rhinitis, where these areas right here, your terminates and your nasal cavities are triggered with inflammation. And what happens again with inflammation? Redness, edema, okay? You start getting those cytokines triggering and making all of this area pretty boggy. So children will not have a fever. They'll have purulent nasal discharge and mucous membranes that are red, okay? And Ava's right. They'll have sneezing, itchy, watery eyes. Okay, so what are we offering for allergic rhinitis for kids? Is it antibiotics? A lot of people do. What's a go-to for kids and allergic rhinitis?
Benadryl?
Doesn't it depend on their age?
Yeah.
Depends on their age, but sometimes, well, first of all, it's to get rid of the trigger. So if they're allergic to something, then limit exposure to that. The second is saline washes. So even if you're a baby, we still do saline washes. It's just a smaller dose. So we use saline in a syringe and kind of wash out the nasal cavity. A lot of it will come out the mouth, but we give mom and dad a saline syringe and they just kind of wash out the area, okay? And that seems to help as they grow. Even with kids, you could buy it at CVS. It's like a spray bottle that just washes out that nasal. If they use that 80% of the time, this allergic rhinitis will go away because it's cleaning the nasal passages of that irritant. Okay. When it becomes acute, so, sorry. Any questions on nasopharyngitis? Okay, so what I want you to know is you can get that from a cold and you can get it from an allergy. And I want you to know the differences between those two. Okay. Let's go to the pharynx. We talked about the nose. That's the beginning of our airway and passageway. And just a reminder, our nose, the hairs, the mucous membranes, all are humidification systems that help us, and clarification systems. So the hair that's in here, the nasal discharge that forms, it's trying to get and capture all the foreign bodies before they go lower into your system, okay? Acute pharyngitis, that's inflammation of the structures of the throat. What are these called on the sides?
Tonsils.
Tonsils. Okay, and this in the middle,
Uvula.
uvula. Okay, you have different sets of tonsils. I'll show you when we talk about tonsillitis in a second, but do you see the white stuff that's on the back of the throat there? What is that called? How are you going to chart that? If I were to ask you about charting that, because it's not, they're saying this here, but that's not how I'm going to chart. I'm not going to say red swollen tonsils with pus spots. Who can translate that in terms of medical terms? What is pus? What's a medical term for pus?
Exudate.
Who's that?
Kayla.
Michaela. Exudate. You guys have heard of that term when we were doing eggs. You guys spell it in the chat. Exudate. That's it. Oops, that's not it. Exudate. There you go. So white, purulent exudate. And when we say exudate, we mean what? What is that?
Pus.
Pus? Yeah, I know. But what is pus?
Signs of an infection.
Okay. It's a byproduct of whatever we've broken down. So if it's bacteria and your immune system's working on that, that pus is the byproduct of all of that, including whatever our immune system has brought there. Okay, so exudate, you're right. It's discharge, it's pus, but what it is telling us there's byproducts of your immune system breaking down what's infecting us. Okay, so most common is Haemophilus influenzae in children younger than 3. Common in 5 to 10-year-old. What do you think is causing that? Annika.
I don't know.
What is the most common throat pharyngitis?
Strep throat.
5 to 10.
Strep throat.
Strep, right? Streptococcus, right? That is a bacterial, right? Virus is also common, but acute pharyngitis. Symptoms are fever, malaise, that overall body soreness, dysphagia. What's dysphagia?
When you can't swallow.
Difficulty swallowing. Difficulty swallowing. Anorexia, they don't eat. Conjunctivitis, this is the conjunctiva, it's inflamed. Rhinitis, cold, and hoarseness. Streptococcal pharyngitis may include a fever that's high. So viral colds typically are low-grade fevers versus bacterial get high. Okay, this will require antibiotics. And this is where I paused for a second. What did I tell you? If we go untreated of a strep A, what can we get?
Clomial, something to do with something your kidneys get inflamed.
Yes.
For the name.
Yes. Anybody help her out? Acute
Acute glomerular
glomerular
Nephritis.
nephritis. And then if we don't treat that, what happens? And this is where I paused for a second in the lecture last week. I said scarlet fever. Wait a minute, maybe not scarlet fever, but I was right. It's scarlet fever. And then if we don't treat scarlet fever, which is usually resolvable, the zebra that I was thinking about is, oh no, it left my brain. Rheumatic fever. That's it. Okay, so we go from strep A to the kidneys, acute glomerulonephritis, and then scarlet fever, and then emergency is going to be rheumatic fever, which could be fatal. I mean, that's the 1800s version of why people died.
Can't you get heart damage from scarlet?
Absolutely. Absolutely. I'm glad you said that, Ava, because our mouth is directly connected to our heart health.
Yeah, because my cousin got it when he was like 2, so my aunt always like worries about his heart because she's a nurse.
He could get vegetative, valvular vegetation, and you can affect your heart. Absolutely. Okay, and that's a proponent of rheumatic fever, is it starts getting some vegetation on the valves. Okay, but remember, your teeth are just a part of your heart health. And I'm talking about kids. So when we talk about dental health, we're really talking about cardiac health. And all the fairs that we hold are because we care about heart disease as much as we care about oral health and oral hygiene. Okay, so things to pull out so far is we looked at nasopharyngitis, cold versus allergic rhinitis, acute pharyngitis, could be viral, could be strep A. If it goes non-treated, a bacterial infection could lead to acute glomerulonephritis, scarlet fever, and then rheumatic fever at the end. Okay, if it's bacterial, you'll know because it's 103, 104 in temperature, that will require antibiotics. All right. Sinusitis, another itis, okay, is inflammation of your sinuses, which are in next to your nasal passageway. Okay, so frontal sinuses are present around 8 years old, but not fully mature until around 18. Okay, proximity of the sinus to the tooth roots often results in tooth pain. So if you have a sinus infection, sometimes you go to the dentist because you think your teeth hurt, but it's because it's connected to your gum structures. Okay, your maxillary, where's your maxillary? On your cheeks, right here, right? And ethmoid sinuses, which are right by your eyes, are most often involved. And our assessment of this, if we were going to see if it's a sinus side, do you guys remember how to assess for sinus infections? We reviewed it quickly in fundamentals. Yes, Ava? She tapped her face. That means there'll be some
Like
tenderness.
when it's tender and like a lot of times it'll be like more puffier than it usually is.
Yes. And then as an NP, we'll actually take our pen light and put it to the cheek. It will illuminate if it's fluid filled there. Okay, that's another trick that we have. So sinus infection usually results when a URI, upper respiratory infection, lasts more than 10 days. Okay, again, this is usually bacterial, so we'll have some antimicrobial therapy, usually antibiotics. Okay. All right. Questions on sinusitis? No? Just so you know, the treatments of these are to try and control that exudate. Okay? Where you are forming, so what do you think would be the treatment of this besides antibiotics? What else can we give to control for exudate and formation of that?
Humidity and moisture.
Humidity and moisture, okay.
Rinse the sinuses out.
Yes, so that saline wash is going to be awesome. And then stuff to hold back the inflammation. So the reason why it's so boggy in here is because, again, inflammation is creating a circumstance to make it more leaky. Remember the cytokines and all those chemical mediators that happen with inflammation create a leakier situation. So some anti-inflammatories sometimes we could put on there too, or steroids to help with controlling for that exudate formation. Okay, so they're starting to have kids do those nasal sprays. And I don't know if you guys are all, suffer from allergies, but those, they're having more and more over-the-counter options, unfortunately. All right. Croup will be our last one before we take a little break. Croup is pretty dramatic when you hear it in kids. Okay, and I'm going to play this little video before we take a break about how croup is affected.
If your child has a loud barking, cough, fever, and noisy, high-pitched breathing, he or she may have a viral respiratory illness called croup. The narrowing of for most.
Is this whooping cough or is this something different?
We can't hear it, Allison.
Oh, you can't?
No. Or I can't.
I can't either.
You can't hear?
No, we can't hear the video.
Oh.
Allison, is this like whooping cough or is this something different?
No, that's different.
Okay.
Could you hear it when I played it on here?
In the beginning, when you first played it, we did.
Oh, okay, then I won't, let me see if I can expand it on. So. Okay. Is that big enough for you to watch?
If your child has a loud
Can you hear
barking,
that?
cough, fever, and
Okay.
noisy, high-pitched breathing, he or she may have a viral
Sorry.
If your child has a loud barking, cough, fever, and noisy, high-pitched breathing, he or she may have a viral respiratory illness called croup.
Croup is a narrowing of the windpipe. And for most of us, it doesn't cause the same symptoms as it'll cause a young child. For a young child with narrowed windpipe, that's a big deal.
Dr. Robert Jacobson says while croup usually isn't serious, it can be scary for both children and parents.
As they try to take a breath in, their windpipe will actually collapse on them, causing them to panic, become fearful, and try even harder to breathe.
Dr. Jacobson says most cases of croup can be treated at home.
We'll take them into the shower to bring steamy air. We'll take them out into the night air to breathe the cold night air. And those things will usually allow the windpipe to relax and allow the air to flow.
If home measures fail, Dr. Jacobson says the child should be seen by a healthcare provider emergently. If you ever fear your child cannot breathe, call 911. For the Mayo Clinic News Network, I'm Jason Howland.
Okay. Let me see if I can de-stretch this. So when I'm talking about croup, it is they're getting stridor. And stridor is a term I want you to always think of as an emergency because it's basically a collapsed airway. And we say stridor in a lot of CPR because it's not getting air in. So It sounds like that. And it sounds like, yeah, like a compressed airway. So weakness in airway walls, floppy epiglottis causes stridor on inspiration. Okay. When the infant's placed prone or propped side-lying position, you'll get less of those symptoms. It usually clears spontaneously as the child grows and muscles strengthen. But there is issues because if we have something that's causing it that narrows those airways or the inlet, you could see here epiglottitis is in that croup syndrome category, swells these tissues and affects the, narrows the airway inlet. Okay, so this is caused by influenza type B, seen in 3 to 6 year olds, can occur any season, rapid, progressive, and very light threatening. So when you hear that barking cough, okay, you're going to, and let me see here if I could play this for you. Sounds like a seal. Hear that? That's an 11th month old with croupy cough. This is stridor. Okay. I'm going to put those 2 media resources for you guys to hear, because that is an emergency sound, okay, that you will need to be more responsive to. All right, I have 6:15. Let's take a 10-minute break and then come back at 6:25. Let me pause this video. Okay.
Okay. So my group had asthma. So 3 assessment findings are expiration, wheezing, nasal flaring, and use of
Expiratory
accessory
wheezing,
muscles when what?
right? Expiratory wheezing.
Mm-hmm.
Okay.
Oh, not expiration, expiratory.
Okay.
Okay. Nasal flaring and use of accessory muscles when breathing. Priority nursing diagnosis, we put impaired gas exchange secondary to bronchial spasm, airway inflammation, and increased mucus production as evidenced by wheezing on expiration. Is that okay?
Yes.
Okay.
Sorry, moving this meeting chat over here. Okay.
2 nursing interventions, we put administer bronchial dilators and assess lung sounds and heart rate before and after nebulizer treatment.
Okay.
And then some parent teaching points is education between the rescue inhaler and preventative medication. Would
Yes.
identify and avoid the triggers to their asthma. Teach them
What's
when
the teaching? Sorry, what's the teaching for rescue versus maintenance?
Well, rescue's only as needed and maintenance is like scheduled, right?
How much is too frequent of use for the rescue? Because that's one key thing is if you're using your rescue inhaler, how many times a week? Ask Dylan.
3,
3?
2.
What do they tell you, Dylan? How long can you use your rescue inhaler per week?
Honestly, I haven't used mine in a while because they told me I got better, so I don't really need it. So I don't know.
Good. But they didn't give you a how much is too much? Okay. Usually it's more than 2 days per week is normally what is we tell them, come visit us. Okay, sorry, keep going.
We put identify and avoid the triggers to their asthma. When to seek further help after rescue medication has no effect or doesn't have the desired effect. So after the 2 times per week, I guess. And then how to use the spacer with the inhaler, how often you can use it, how to use the nebulizer. We also put education on positioning on semi-foulers or high foulers. Recognize the symptoms like the labored breathing, inability to speak, like meaning like during like an asthma attack, decreased level of consciousness, and cyanosis.
Awesome. So when you do the rescue inhaler, what is the key teaching?
Breathe out before breathing in.
Good. What else?
Hold it in for a couple seconds.
Yes. Because what the kids tend to do is, like, you're going to have them demo how to use that. And then we used to be able to teach when to know it's empty. But the design is different now. We used to say, oh, if it floats or blah, blah, blah. But now the new rescue inhalers, they don't have that water test anymore. Excellent.
I have
Okay,
a question. The inhalers is when you have to do the oral care after, right?
Yes, like what?
I don't know, rinsing your mouth, right?
Rinse your mouth out. So the 2 big things that can happen with rescue inhalers is I don't use my spacer and I shoot it at the back of my neck and it just drips down, which means it doesn't work. And that's typically what happens is they go, man, this rescue inhaler doesn't work. It sucks. It's how they're administering it to their kid or how their kids are administering it to themselves. And then the other part is, again, 2 days a week, you're not using your maintenance dose appropriately, or we need to put you on a different regimen to help support. And then the third one is the trigger. Okay. And I'll give you an example, one that happens all the time. What's one of the major triggers that I see happen in the clinic? Can you guess what besides dust that Dylan had pointed out, what's the second one?
Is it smoke?
Smoke, absolutely. So the parent that smokes brings in the kid, and I'm like, okay, well, obviously we know where the trigger is. And so I have to do the teaching to the parent. You're going to now have a smoking jacket. Have you guys heard of that before? Smoking jacket? Where they used to wear a jacket when they go out and smoke, then they take it off and leave it outside. And so we have to teach them to have that kind of method, because more and more that you smoke, not only burning off your ability to smell the smoke on yourself, but you're going to just carry that for your kid. And then it starts to get into the curtains, into the furniture. And so that's what we see. We kind of have to do a patient teaching on triggers. All right. Excellent. Next.
We can go next.
Okay.
So, we had RSV. 3 assessment findings are wheezing on escalation, and then it occurs because
what? Wheezing on what?
Wheezing when you listen to their lungs.
Wheezing on auscultation.
And then it occurs because there's inflammation and swelling in the bronchioles. Retractions of nasal flaring. That's a sign that they're having a harder time breathing. So there's decreased oxygen exchange. And then tachypnea. Increased respiratory rate. So it's caused by inflammation and mucus obstruction as well. Some additional assessment findings are like cough, thick mucus, and crackles.
What else? Infants. You're missing one. You said flaring, retractions. What's the other one?
I don't know.
Infant. Annika? If you no? Anybody?
Is it grunting?
Grunting. Grunting, flaring, retractions. All right, go ahead, Onamar, sorry.
Everyone's sharing their own.
Sharing?
And then I did the nursing diagnosis for the
Oh.
RSV, and that would be impaired gas exchange due to bronchial obstruction, inflammation, edema, evidenced by, was it hypoxemia, tachypnea, tachypnea, restlessness, tachypnea, irritability, cyanosis, and another one.
Hopefully not cyanosis.
That's the late sign.
Late sign, yes.
Late sign. And then another nursing diagnosis would be ineffective breathing pattern due to airway obstruction as well. Tachycardia, wheezing, retractions, and then decreased oxygen saturation.
Okay. What else?
Okay.
Interventions and parent teaching points.
For interventions,
Mhm.
like you're gonna monitor the respiratory status. You're gonna assess the respiratory rate, the oxygen saturation, the work of breathing, and the lung sounds regularly. You're gonna watch for signs of respiratory distress, such as nasal flaring, retractions, or cyanosis.
No. What was our third one?
Oh, grunting.
Grunting. Thank you.
And then the second intervention will be maintain airway clearance and adequate oxygenation. You're gonna suction nasal and oral secretions as needed, especially with infants and young children. Administer supplemental oxygen as prescribed to keep oxygen saturation within the target range.
And what was the special device that I mentioned for infants?
It was like the olive tip or mushroom
Olive tip. Absolutely. Excellent. And then chest physiotherapy. We do teaching on discharge for parents. That's the cupping. We'll talk about that when we talk about cystic fibrosis, but that is a way to kind of help the drainage come. Okay. All right. What's the last one?
I did the last one, the parent teaching points.
Yeah. Mm-hmm.
So infection prevention at home, hand hygiene, wash hands frequently and thoroughly, use liquid soap. RSV survives on bar soap. Wash hands before and after caring for infants. Surface cleaning, clean hard surfaces regularly, countertops, doorknobs, toys. RSV survives 6+ hours on non-porous surfaces, and RSV survives up to 2 hours on tissues, fabrics, and papers. Limit exposure, avoid close contact with people who have cold or respiratory symptoms. And then keep infant away from crowded places during RSV season, November through March. And then siblings with cold symptoms should avoid close contact with infants. And then recognizing respiratory distress, call provider immediately if increased respiratory rate or difficulty breathing, wheezing or noisy breathing, nasal flaring or chest retractions, decreased feeding or fluid intake. And then decreased wet diapers less than 1 to 2 ml per kg per hour. And then lethargy or increased irritability.
How do you measure that if they're on a diaper?
Usually is 6 diapers a day. But if decreases less than 6, then that should be a concern. And
Excellent.
then let me see. Oh, yes, hydration, offer frequent small feedings, monitor for adequate wet diapers, watch for signs of dehydration, airway clearance, use bulk syringe to suction nose before feedings, keep infant's head elevated during sleep, provide
Good.
guidance, and maintain smoke-free environment. And then also monitor and watch for breathing patterns closely, note changes in feeding behavior, and track fever and activity levels.
Excellent. Great. All right. Good job. Group 3. Not number 3, but who wants to go next?
We can go next.
Who's we?
We had pneumonia.
Pneumonia. Excellent.
So three assessment findings would be crackles and auscultation of the lungs, a productive cough, and shallow breathing. 2 interventions would be to monitor their O2 and apply oxygen if needed, and encourage coughing and deep breathing. Nursing diagnosis we got from the book, breathing difficulties as evidenced by rapid respiratory rate retractions and nasal flaring. And for parent education, we got no tobacco use around the child, finish prescribed medication, hand washing, cover the mouth when coughing, and let the parent know that rest is an important part of healing. So make sure to not disturb the child.
It's usually the other way around, but oh yes. When the baby's sleeping, usually the parents are like, cool, we're not going to bother them. Awesome. So pneumonia could be both bacterial and viral, right? How do they know the difference?
The bacterial, the child would have a fever over 104.
High fevers with bacterial, low-grade fevers with viral. Very, very good. Excellent. Last group. Group, right? Let's go.
So for group 3, the clinical findings are the inspiratory stridor, the high-pitched harsh sound that's mainly heard when expiration or breathing in. It shows an airway obstruction or upper airway, and it's even present at rest. The barking cough, it's usually characterized as like brassy or still-like, caused from inflammation in the larynx and subglottic airway. It can worsen at night or when the child is agitated. And then the third one is a hoarseness, a change in voice that can be raspy, and it's from the inflammation from the laryngeal area or vocal cords in the throat. These signs can kind of vary depending on the severity, and it can show an increased work of breathing, chest wall retractions, tachypnea, and nasal flaring.
Tachypnea.
Okay.
Nasal flaring. Yes. So I'm going to try to correct you guys on medical terminology, right? I'm sorry, NIE.
It's okay. For the priority nursing diagnosis, we put ineffective airway clearance related to inflammation and swelling of the upper airway as evidenced by barking cough, stridor, and increased work of breathing.
And just so you know, stridor is usually an upper airway constrictive issue versus your asthmas and pneumonia or your lower airways. Very good.
For the nursing interventions, the 2 main things are increasing humidity and fluids, whether it be IV or regular fluids. You only said 2, so I'm only gonna say that.
Thank you, Kina. It's hard. By the way, it's hard to drink while having that croupy cough. and there's also aspiration risk. So usually it's IV if we can get it in them. All right, last ones.
Parent teaching points. I got use cool mist humidifier at home. Make sure you empty, wash, and disinfect it each day to prevent growth of microorganisms. That was in the book. 2, encourage fluids. 3, avoid exposure to smoking. 5, allow child to rest, wash hands. Place infant in a prone or propped in a sideline position to lessen symptoms. And then I put seek immediate medical attention if child develops stridor, at rest, increased work of breathing, cyanosis, or difficulty swallowing.
It says to place them in a prone position?
That's what she said in your PowerPoint.
And the book.
For how long? I'm looking at the book.
I don't think it says how long. It just says like you need to be careful like when it's a younger like infant because of SIDS. But but you could put on an apnea monitor may be suggested if a prone position is necessary.
Okay, so the only reason I'm clarifying is, let me make sure I put that.
It says a prone or side-lying position helps with the symptoms.
All right, so if I was live with you, I'd be grabbing a doll right now because normally you grab the baby by the neck, okay, and that's when you can kind of have them overhang and you do that chest cough. But if you're talking about prone position, that's what the intent is, to have them kind of forward and draining. Otherwise, there's aspiratory risk. But always back to sleep, even if propped, usually mom's holding the baby with them, so they're kind of elevated. All right, excellent choice and group presentations. I'm glad my my breakout room skills were valid right there. All right, so let me unshare this real quick. Still no break? You want to keep going?
Yeah.
She's like, just all the way. Okay. Yes.
My butt is hurting from sitting.
Okay. Well, that's what I'm saying. Do you want a break to stand up?
No, I want to.
No, it's 8:50.
We only have a little bit.
We have an hour. Okay. So I'm going to go slow. No, I'm just kidding. Okay. Let me bring up my PowerPoint again, since you enjoy it so much, Annika. I'm going to move you guys over here. So I'm going to side screen you over here. So again, if I'm looking this direction, it's because I'm looking at your faces, even though the camera's right here. All right. We'll get it moving, get you going. My vitamins kicked in, so I feel a little bit better. All right, cystic fibrosis. This is the second part. We're going to focus on cystic fibrosis. A lot of the genetic diseases, stuff that is part of the congenital defects that happen. So we'll look at also bronchial pulmonary dysplasia and prevention of that. Prevention of SIDS is how we'll end, okay? So a little bit more. All right, let's look at cystic fibrosis. Cystic fibrosis is a multi-system disease which thick, viscous, I don't know what this is. It's supposed to be viscous secretions are here, which affects the lumen of
If
your
you're trying to
bronchiole.
show at the slides that we can't see anything.
You can't see? Let me share again. Hold on. Let me try. What about that? What are you seeing my slides? Okay. Right here. So this lumen, not only are the arterial walls thickened, but then you have mucousy blood in these dilated airways. Okay, so cystic fibrosis is a multi-system disease. It affects not only the respiratory system, it also affects the digestive system. So these kids also have to take enzymes in order to digest their food. So digestive system secretions prevent the enzymes from working in their GI tract, and it prevents their absorption of food. So what happens if you don't absorb the food? What kind of states will we have?
The nutrients.
Yes. And just like that,
Malnutrition. What is it, like malnutrition?
not malnutrition.
Nutrition
Well, yeah,
deficiency?
it is malnutrition, but how will that show up, huh? What do you say, Dylan?
Nutrition deficiency?
Yes. And how does that show up on kids? What's the markers?
Failure to thrive, something like that.
Failure to thrive. Hello, Annie. Okay. They will not gain nutrients. They will not grow appropriately. Okay. So you'll see that show up on their growth charts. Failure to thrive. Absolutely. So bulky, foul smelling stools that are frothy because of that undigested fat content. So we have to give them, and they'll be on this for life, is supplemental enzymes that they have to take with their food. Their skin, loss of electrolytes in sweat causes their skin to be very salty. In fact, there's crystalline formation sometimes on their skin that shows up. Okay. Reproductive system secretions also affect their sperm motility and cervical mucus. So what do you think happens with couples that have cystic fibrosis? If one of them has cystic fibrosis, it'll lead to also infertility issues. Absolutely. Okay. Not only will it affect sperm motility, but again, cervical thick mucus inhibiting that fertilization happening in those fallopian tubes. Okay. So it's a secretion issue. Our nursing care is around helping to drain it, to loosen it, okay, and to have it not affect oxygenation. So here's a little video. See if we can play it on here.
Let's talk about cystic fibrosis. Let's begin with the pathology behind cystic fibrosis, also commonly referred to as CF. Let's talk about cystic fibrosis. Let's begin with the pathology behind cystic fibrosis, also commonly referred to as CF. Cystic fibrosis is a disease caused by a genetic mutation which prevents exocrine glands in the body from working properly. Healthy exocrine glands secrete easily through ducts, where in cystic fibrosis we have stuck, thick mucus. What do exocrine glands do? These glands produce and transfer secretions through ducts. Examples are mucus, tears, sweat, and enzymes. When there is an exocrine gland malfunction, like in cystic fibrosis, the secretions become highly viscous or thick. Let's talk about its impact on the ciliary function. In our bodies, the cilia are like tiny little fingers, which move mucus around and out of the body. In a healthy system, there is little difficulty, but in cystic fibrosis, there is resistance to ciliary action, which slows the rate of mucus movement. So secretions have a difficult time moving and they become stuck, which leads to something called mucus plugging. This mucus plugging is when the mucus becomes too sticky and creates a plug. This causes necessary avenues in the body to become infected, such as the reproductive organs, airways, and GI passageways all become blocked with that thick mucus. It's important to know that there is no cure for this disease. All care is focused on management only. However, there are some medications to help make the disease more manageable. Mucolytics may be used in patients with CF. These drugs help to break up mucus so they can be more easily expelled or coughed up. A common example is Pulmozyme. Bronchodilators are used to open the airways, leading to improved air exchange. An example would be albuterol sulfate. The next is pancreatic enzymes, which help to replace the deficit in protease, amylase, and lipase. Remember that these should be swallowed whole or sprinkled over acidic foods. Antibiotics are often used to prevent and treat respiratory bacterial infections. And corticosteroids may be used to decrease inflammation in the airways. We can also use non-pharmacological care such as chest physiotherapy, increased fluids, and diet modifications are necessary for proper management. Let's look at some things the nurse should be monitoring. We want to monitor the lungs for wheezing, bronchi, and crackles. These can all indicate mucus plugging or infection. We also want to monitor oxygen saturation and for signs of respiratory distress, such as dyspnea, audible wheezing, or use of accessory muscles. We also want to monitor the patient's bowel sounds. Hypoactive or hyperactive bowel sounds may indicate an obstruction, as well as distension, firmness, and tenderness. And lastly, we want to monitor electrolyte imbalances, especially hyponatremia due to that excess sodium loss. If you want the rest of this video, check out Nurse in the Making Plus. This includes access to our growth.
No, thank you. We have our own. Okay, so cystic fibrosis. Here is, I'm just going to tell you a point of contention that's happening in your scope of practice. A lot of these kids get managed at home by LVNs because now we can't titrate oxygenation. A lot of these kids are getting sicker and being brought into the hospital. So home health, we would go out, do chest physiotherapy, give some IV fluids, give some oxygen, okay, make sure they're taking their meds correctly, and then do that chest physiotherapy. So chest physiotherapy is either, we're doing this, where we're doing cupping. I used to teach them, take the mask off of an ambu bag and use that as your device to break down all the mucus, right? The other part is, I don't know if you saw in that video, there's 2 chest straps. You can actually have a machine that's bought that will do the vibrations and kind of loosen those secretions so that you could take mucolytics and suction that out, okay? So it not only affects the respiratory system, but the GI system. So it is going to coat the gut to where you have decreased absorption and affects your enzymes. And then what's the other system that that we said got affected? The skin, right? So your skin will discharge some sodium, and they're at risk for hyponatremia. Okay? What's hyponatremia? How do we see that on our labs? Mo?
Is that high sodium?
No, hyponatremia.
Low.
What are my numbers?
Below 135.
Ooh, good for you. 135, 145. Remember how I remember that is, I don't know why, but I tie it to my pH. 7.35 to 7.45. 135, 145. I don't know why I put those together, but that's how I remember them as a nursing student. Okay, I'll put this video on your website as well. It should be clickable on your slides. Our goal for cystic fibrosis is all those secretions that aren't getting out are putting us at risk for infection. So a lot of these kids get bacterial pneumonia, recurrent, and it ends up scarring and making tissue where it's stiff. So we want to prevent infection by doing that chest physiotherapy systematically, trying to get all of that mucus to soften up so we can secrete it out. Oral pancreatic preparations. I don't know if you caught, how do they use those pancreatic enzymes?
They dust it with the food?
Yes, sprinkle it on their food, especially acidic foods. So diet should be high in protein, high in calories. Okay? And that's because, again, they have decreased absorptive abilities. And so the more high calories, the more they can intake, even if it's not being absorbed. Okay. General hygiene, care for, if it's infant, care for the diaper area. Frequent changes in positions to prevent that pneumonia. Okay. Light clothing to prevent overheating. And teeth may be in poor conditioning because of those dietary deficiencies and lack of enzymatic breakdown of their food. Long-term care, the prognosis is we used to have them only be in the teens, but now cystic fibrosis, late 20s, 30s, there's a good, quality of life that happens. Goals is to minimize those pulmonary complications, adequate nutrition, promoting growth and development. It's usually an issue of failure to thrive and infection more than it is just the disease. Okay, so cystic fibrosis is about thickening of the secretions, okay, and that it affects the GI, the skin, and the respiratory tract. All right, a couple more diseases and we'll go. Bronchopulmonary dysplasia leads to a respiratory distress system. BPD is when the lung tissue becomes stiff. That's what that dysplasia means. It's a major reason why newborns have difficulty with oxygenation and need to be put on ventilator use. Okay. The main reason is prematurity. Do you guys remember what happens with prematurity with infants?
Their lungs are not fully developed.
And
they don't have
the surfactant.
Exactly. So surfactant is going to make that less stiff, right? Remember we used to give mom medication to increase surfactant. So prematurity is the issue of why their tissue is stiff. Okay, so the goal of treatment is to administer oxygen to prevent hypoxia. Hypoxia versus hypoxemia. Hypoxemia is the free-floating oxygen in the blood. Hypoxia is at the tissue levels. Okay, at the minimum ventilator pressures needing to produce tissue, prevent tissue trauma. And then again, antenatal steroids to help hasten the lung development. So do you guys remember what we gave mom in order to develop lung tissue?
Steroids?
Which one?
Magnesium.
Oh, I don't know.
No. You know. You just got done with maternity. Anybody? Betamethasone? Okay. Administrations of surfactant within 15 minutes of delivery may also be helpful to baby. But this is what happens. The normal alveoli are inflated, round, and pliable. When you're premature and you have lack of surfactant, you get collapsed, damaged alveoli. Getting ready for what? What is this getting ready to do? What do we call this? Why do we do IS? To prevent what?
Is it gonna collapse?
Yes. What's the fancy term for that?
Atelectasis.
Atelectasis. So that's what these damaged alveoli can do. They're stiff, non-pliable. They affect gas exchange. So what they hear is wheezing, retractions, cyanosis, use of respiratory accessory muscles, clubbing of the fingers. Again, failure to thrive, meaning you cannot eat. Irritability caused by hypoxia. All right, last topic before I let you go, sudden infant death syndrome. SIDS is unexpected death due to, we don't know. But usually it's a respiratory issue. Happens between 2 weeks and 1 year of age. Our biggest proponent, our biggest teaching for SIDS is what? What's the slogan for SIDS?
Lay the baby on their back.
Back to sleep. Back to sleep, right? So the clinical features of this is death occurs during sleep. Infant doesn't cry or make other sounds of distress. The parents just find the baby gone in the morning. Sudden infant death syndrome. So it's a respiratory issue where they're not being able to have cardiorespiratory control. Some thought it's caused by a brainstem abnormality or overheating. So irregulatory respiratory patterns, decreased arousal response are contributing factors. So back to sleep, nursing for the first 2 months, okay, and vaccinate. Don't overheat the baby. Cover the baby with a blanket, co-sleep, which could lead to suffocation, and then surround with toys. So usually we're teaching parents to not have anything else in the crib to avoid suffocation. Okay, the risk factors include smoking or cocaine use during and after pregnancy, preterm birth, and then post neonatal care. All right, we ready to do this exercise? So we're going to end a little early. You're welcome, Annika. I know that you wanted to stay longer. Okay. Wednesday is midterm. Do you see me?
Yeah.
Okay. If you want to do a review, which is what I would have done with you in the time remaining, but I think you guys are burnt. So what I'll do is you guys will just have to do the questions, the review questions. And then if you have some questions for me, I always have office hours. How many of you are in clinical tomorrow?
Me.
Okay. So
me.
Wednesday morning, I have options, or we can always do a Zoom during your break.